toward safety, smarter, and more resilient healthcare for all. Thank you.
Thank you, President Chen. So next, I will introduce the first moderator. Next, Professor Lin Qin-xiong. Professor Lin Qin-xiong is a supervisor in Taiwan Healthcare Quality Association, also deputy superintendent in Changhua Christian Hospital. Professor Qin-xiong Lee, please.
Okay, thank you. Good evening, everyone. I would like to thank President Zheng for his warm opening remarks. I am Dr. Qin-xiong Lin from Changhua County. It is my pleasure to serve as our first introducer of our keynote session tonight. And it is my honor to introduce our first keynote speaker, Dr. Shih-Ying Chen. Dr. Chen is the Deputy Executive Officer of the Sustainability Office and an attending physician in emergency medicine at the National Taiwan University Hospital. And he also served as a supervisor of the Taiwan Healthcare Quality Association. And as an emergency physician, Dr. Chen works daily in one of the most challenging environments for diagnostic decision-making. And tonight, Dr. Chen will share his perspectives on getting diagnosis right, the next frontier of patient safety. And please join me in welcoming Dr. Chen, please.
Good evening, everyone. Thanks for Professor Huang's introduction. Today, I will discuss why diagnostic safety is emerging as one of the most critical frontiers in patient safety worldwide. The topic aligns closely with the 2024 World Patient Safety Day theme, Get it right, make it safe. I will share global insights and practical strategies we can apply in our daily work. Let me begin with a brief history. A middle-aged patient presented with abdominal pain to the emergency room. Initial tests was done, but the CT scan results showing early appendicitis, which was not reviewed until the next day due to workflow delays. The patient deteriorated overnight and required emergency surgery. This example is not about blaming individuals. It illustrates how delays in reviewing results, unclear responsibility, and the communication gaps can turn an initially manageable condition into a patient safety event. Although diagnostic processes are central to healthcare, diagnostic errors have historically been overlooked. Globally, they contribute substantially to preventable morbidity and mortality. Importantly, diagnostic errors are rarely the result of a single clinician's mistake. Instead, they arise from system-level issues such as incomplete information, workflow disruptions, or communication gaps. Recognizing this, WHO dedicated the 2024 World Patient Safety Day to improving diagnostic accuracy and timeliness. Studies estimate that diagnostic errors affect millions of patients annually worldwide. Primary care emergency departments and pediatrics are particularly vulnerable. High-risk conditions such as cancers, serious infection, and vascular events accounted for a large proportion of preventable harm. System fragmentations and poor coordinations further widen the disparities. Diagnosis is not a single act, but a complex process involving history taking, physical examination, test ordering, interpretation, follow-up, and confirmation. Each step depends on accurate information and seamless coordination across various disciplines. Failures, whether cognitive or systemic related, can be occurred at any stage. In general concepts, diagnostic failure has been classified into three types. One condition is that the diagnosis is made too late to be effective. Another one condition is that the diagnosis is incorrect, Sometimes the diagnosis is never met, even the disease symptoms repeatedly presented. But a more comprehensive perspective is that diagnostic errors is not limited to fail to make correct diagnosis, but also includes failure to communicate or act on diagnostic information. Increasingly, we look at diagnostic safety through a systemic lens. Which parts of the diagnosis journey consistently fail or created vulnerability? Several system-level contributors are well recognized. Patient information may be scattered and forming so-called information islands, or the incomplete information transmission. The test results may not be tracked reliably. Work overload and time pressure increase cognitive burden. Communication between teams and may rely on informal or unreliable channels. Finally, some organization cultures still discourage open discussion of diagnosis uncertainty or near miss. So how can we cope with this challenge? I think the first strategy is to redesign diagnostic process for safety. The first is standardization of the diagnostic pathway, reduce variations. Checklists of high-risk symptoms such as chest pain or fever in children ensure essential steps are not missed. Systems for tracking clinical test results ensure timely review and intervention. Even simple changes such as clear responsibility assignments can prevent delays. Digital tools offer enormous potential. Decision supporting systems or even AI-enhanced decision supporting systems in the near future can reduce diagnostic variations. Automatic alerts can identify results that was not followed up. Dashboard can show diagnostic timelines and highlight bottlenecks. However, these tools must be used wisely and carefully. AI systems may have hallucinated answers or amplified bias if training data are not complete. Alert fatigue is real and the technology must assist rather than replace clinical judgment. Patients and families can be powerful partners. Encouraging them to ask questions, request clarification, or verify results adds an additional safety layer. Transparent sharing of results helps ensure nothing is overlooked. A co-production approach recognizes that patients are essential contributors to a safe diagnostic journey. Improving diagnostic safety requires a supportive culture. Diagnosis is inherently uncertain, and acknowledging uncertainty should be seen as professionalism, not weakness. Reporting near misses offers valuable learning opportunities. Teams must feel empowered to voice concerns and clarify discrepancies. Organizational leaders must ensure clinicians have the time and the resources they need. Diagnosis can be measured. Institutions can track the timeliness of revealing results, follow-up of abnormal findings, and diagnostic-related instance reports. Complaints, especially from patients or from other customers, often provide important clues. Using dashboards, or statistical process control charts help detect patterns of the deviation earlier and supports continuous learning. Let me share the first simple hospital examples. One institution implemented a test result tracking dashboard integrated with automatic alerts for overdue reviewers. It is especially important for life-threatening clinical test results such as hyperkalemia. We combine technologies with clarified responsibility assignments and the staff educations. Very quickly, the rate of the delayed review of critical results dropped significantly. This demonstrates how system redesign can measurably improve diagnostic safety. We so-called this is a patient message board. When patients reaches online, a patient message board appears after the appointment is completed. They may enter their symptoms or concerns and even any questions for the physician. Then they click submit. It is very helpful for elderly patients who usually forget what they want to tell or what they want to ask for doctors when they physically seeing the doctor. Many of this information might be important for doctors make correct diagnosis. And then the physicians can open the patient message board in the clinical operation systems by selecting it from the reference informations. The panel is on the right to view the patient's submitted message. So it facilitates the communication between the patient and the physicians. To make progress, we can start from small. Identify one high-risk diagnostic area, map the failure points, implement one improvement, whether workflow or digital, collaborate with one patient in co-design, measure one meaningful metrics. Change begins with actionable, manageable steps. In closing, diagnosis safety is both urgent and achievable. By shifting from blaming individuals to redesign and redesign the systems, we create safer environments for patients and clinicians. Digital tools, when used thoughtfully, offer valuable support, and the patients themselves are indispensable partners. Thank you for your attention. Together, we can get it right and make it safe. I look forward to your questions. Thank you.
Okay, thank you, Dr. Chen, for your very insightful presentation and your emphasis on diagnostic safety as a system challenge and three priority area: safer workflow, digital tools, governance, and patient engagement, and give us a concrete direction for improvement. And now I am pleased to hand over my job to Dr. Chongbin Huang, and he will introduce the international keynote speaker from Japan. And Dr. Huang, the floor is yours.
Yes, thank you, Professor Lin. Ladies and gentlemen, good evening. I am Dr. C.B. Huang. This is my great honor to introduce next keynote speaker, Professor Ushiro Shin. Professor Shin got his MD and PhD in Kyushu University in Japan and has research training in cell biology in New York University Medical Center in the USA. He was Deputy Director and Divisional Director of the Division of Patient Safety in Kyushu University Hospital in Japan. At institutional level, he has been engaged in a wide range of quality and safety improvement, such as incident reporting system. Most important is he received the ISQA Lifetime Achievement Award in 2025. Professor Shin is now the country representative board member of ISQA and ASQA. Also is Deputy Superintendent of Kyushu University Hospital and the Professor of Faculty of Medicine in Kyushu University. He's also member of the Global Ministerial Summit Series on Patient Safety with delegation of UK and national delegate expert of G20 Patient Safety Leader Group. And today he will give us a talk with the title of Digitalization of Healthcare and Patient Safety. Let's welcome Professor Ushiro Shin. Professor Shin, please.
Hello, my Taiwan colleagues joining Taiwan Healthcare Quality Association webinar. I'm Shih-Ying. I'm here in Geneva to attend International Hospital Federation Conference. And I'm from Kyushu University Medical Center, where I work as a deputy director in charge of patient safety, as well as a board member of JQ, which is an accreditation body in my country. And at the international level, I work for ISQA and ASQA, ASEAN ISQA, as a board member or committee member, etc., etc. And I'm really honored to be invited to this wonderful occasion to talk about digitalization in healthcare and patient safety. So let's get started. Well, you see overview of digitalization dubbed as DX in healthcare in national plan in my country. The government is now promoting integration of all those data related to healthcare for better and safer and effective and efficient care, as well as accurate healthcare billing and payment, and even for research use to develop a new drug. And in the middle, you see one smartphone and one card. I'm going to talk about these two items in the next slide. What is displayed on this smartphone is called My Number Portal Site or MyNumber Portal Site. My Number Portal Site was originally developed for a wide variety of public service procedure and confirmation, such as moving in, moving out procedure, healthcare expenditure confirmation, insurer verification, which is really important, rate of co-payment verification. If we are not aware of the rate, we may pay more or we may pay less, etc., etc. Now this minor portal site is now highlighted in terms of integration with personal data of other areas other than administrative areas such as healthcare. Well, here you see on your left-hand side is the Gantt chart produced by the government for the integration. In step 1, the government is trying to integrate my number card with medical insurance card. And in step 2, the government is integrate the data of number 1 with healthcare data and medication data. And with those data, the government is going to integrate the data of step number 2 with nursing care data and social welfare data. And finally, the government plans to develop very precise electronic healthcare billing and payment system. Well, this is the final outcome of the integration along with the government plan. So I'm sorry, there are a lot of my local language. I'm going to translate them into English in the next slide. And with this slide, I'd like to tell you about what type of data is integrated and who is sharing those data. Here you see medical care data, a database, including electronic prescription, electronic health record, etc., and nursing care database, nursing care plan, etc. and public health social welfare database such as public subsidized care, vaccination, etc. And those data are shared by hospital, clinic, and pharmacy, emergency transfer system, medical care insurer, healthcare researcher, government official, nursing care provider, nursing care insurer, so that we will achieve seamless data sharing in continuum of care and efficient provision of public services. Better advice with integrated data through minor portal site and research use of data for public health, medicine, healthcare industry advancement under the condition of anonymization of those data. Well, I'd like to highlight one of the data to be integrated, which is electronic health record data. Essential data on electronic health record is shared with hospital, clinic, and community pharmacies. And 4 vital pieces of data on EHR will be shared. Number 1, referral sheet with discharge summary. This is the latest clinical data. Number 2, data of health screening conducted by workplace, municipalities under the government's regulation. 6 vital data such as diagnosis, contagious blood microorganisms such as HPV, allergy data to drug, allergy data to other chemicals, laboratory data, and prescription data, and the summary of clinical history. Those 4 pieces of data will be shared. Well, another data I'm going to highlight is the prescription data. And the government has launched electronic prescription system. The big data server is located in public healthcare insurers, to which not only patient but also physicians in medical institution and pharmacists in community pharmacy can have access, so that physician and pharmacist would eliminate duplication in prescription or elimination of wrong prescription, and the early detection of side effects or allergic reaction due to previous prescriptions. So we believe that this system will be very helpful for patient safety, particularly medication safety. Well, let me tell you once again the benefit of hospital and clinic. It obtains data of previous prescription issued in other institution within 1 month. It allows careful interview with the patient on medication therapy. Prescription is audited through the system. Easy duplication, redundancy, contraindication, leading to safer medication therapy. The same benefit applies to community pharmacy. But one thing more, community pharmacy will no longer need to store paper-based prescription sheet in their facility. As I said, integrated data will be shared with research institution or pharmaceutical industries for research and development of new drugs. And how it works is that the data of hospital, clinic, and municipality, such as health screening, clinical consultation, and treatment, is provided to minister's certified data provider. And the data provider is certified on condition such as confidential data protection and a strict data protection system embedded in data management system in their institutions. And the certified provider anonymize healthcare data they got, and it is provided to research institution and pharmaceutical industries. And the outcomes of research and development returns to our society. And obviously, our nationals, individuals are allowed to opt out from this system. So question at this point is how to promote and accelerate the data integration. Here you see the book on price list in healthcare payment system. It's a big book, over 2,000 pages. An individual procedure management guidance has its own price. The government is now trying to provide financial incentives. The price list was recently updated in 2024 to include new updates, new items related to the promotion of the integration. For instance, healthcare digitalization promotion extra fee, home care digitalization promotion extra fee, facility level cooperation extra fee when the physicians share data electronically during thrombectomy for brain stroke, and more are included recently in our price list for promoting integration. Well, legislation is one of the powerful tools for promoting digitalization, data integration, even in healthcare industries. This year, our Diet passed the bill called AI Act 2025. And conventionally, our government has been in favor of regulation rather than promotion. However, AI Act 2025 is trying to balance promotion and the risk management of their AI development, so that we would get benefit, maximum benefit from AI development. Well, I think we all agree with the idea that AI works very well not only for clinical work but also for administrative work. For instance, the AI would work well for production of documents, easy clinical summaries at patient admission or patient discharge, production of operative record, and consent process record, etc., etc. So in addition to the benefit for medical professionals, a patient will receive benefit from AI development. Here you see newspaper article of New York Times published this year. And my friend Sue Sheridan, who is a patient and family representative of the United States, is highlighted in terms of her experience with on AI. And one day, she suddenly suffered facial drop, facial muscle paralysis. And then she asked ChatGPT for diagnosis. And she got a diagnosis, which is Bell's palsy. And she quickly visited her physician, and the diagnosis was correct. And she received quick treatment, and she achieved quick recovery. That was the story of this article. So if wisely using AI, patient would get benefit. Well, AI has already arrived at Kyushu University Medical Center where I work, so I would show you how it is working. For instance, AI is involved in the consent procedure. Here you see the microphone and IC recorder as well, and the physician focuses on explanation for consent about surgery rather than writing what he said or she said on electronic health record. An AI embedded in our electronic health record quickly produces text data shown here from a recorder in IC recorder. We know that this is too much, so AI quickly summarizes massive text data into the data short enough for electronic health record. So physician copy this data onto the electronic health record. AI also produce operative record, draft operative record, which is to be confirmed by operating physician. And since we are accepting increasing number of patients from other countries, we need to write the operative record in English. AI helps us in translating our operative record into English quickly. And when the operation is conducted, we share our the operative record, short operative record, with the physician who transport patient to our institution. So here you see the prompt, and along with the prompt, AI summarizes long operative record into a short record, and we copy and paste this on a letter to a physician who referred patient to our institution. Well, AI is now working effectively in disaster hit area, particularly in healthcare institution in the area. Last year, on January the 2nd, Noto Peninsula in my country was hardly hit by a big earthquake, and a lot of infrastructure, including healthcare institutions, collapsed, and the significant number of people evacuated from the Noto Peninsula, and the many people didn't come back due to family reason or etc. etc. So now the medical institution in Noto Peninsula is in significant shortage of clinical staff. So AI is now helping the medical professionals who remained in the institution for efficient and effective healthcare provision in such a way that AI produces draft referral document, and AI standardized treatment process, and AI activates high efficiency, making up for shortage of frontline of workers. Well, in order to give you another example of the value of AI application, I'd like to switch my subject to the national level reporting and learning system. And some of you may know that I have been in charge of running national level reporting and learning system funded by the government in JQ for nearly 2 decades. We have different kinds of reporting and learning system at the national level, covering institutions such as medical institution, hospital clinic, community pharmacy, and dental clinic, as well as clinical conditions such as cerebral palsy, coupled with no photocompensation, and accidental death. Well, our reporting and learning system, particularly original one, provide a massive database of adverse event and near-miss event. You can choose adverse event or near-miss event or both, and you can type keywords of your interest, such as dialysis, and you will see nearly 2,000 adverse events are matched, and you can browse individual cases, and you can even download the cases of your interest onto your computer swiftly in different format of digital files. So we provide a database. It means that we have been providing massive text data of adverse event and near-miss event. And one day, AI researcher visited me, and we launched joint project to develop AI model. We chose BERT, which is similar to ChatGPT, and we trained BERT with massive language data in the first step, and before the second step, we produced the gold standard data of medication safety, which is fully structured with each phrases and words labeled with what it means. And in the second step, we trained BERT with our massive text data of medication safety, and in the final step, we trained BERT with the gold standard data. And now our trained BERT AI model is producing beautifully structured data with fully annotation, which is limited to medication incident. But we are going to expand the scope of our incident structured data in the near future. So as I said in my previous slide, our AI model, trained BERT, is now producing massive structured data with fully annotated words and phrases in such a way that Monday is the date, levofloxacin is the drug, and it even identifies amount of drug to see if it is actually originally intended or actually administered to conclude if the case is overdose incident or underdose incident. Well, I'm going to give you another example of the database. As I said, JQ has been running no-fault compensation investigation prevention system for cerebral palsy since 2009. I have been in charge of running this system. And in this system, we provide monetary compensation on no-fault basis, as well as we produce investigative report and carry out the sharing of corrective action obtained from the collective analysis of investigative report. Well, in addition to the production of investigative report, we also produce synthesized version of investigative report for transparency, and we put all of them, as many as 4,000 and more, on our website. Now it means that we have been providing massive text data related to cerebral palsy available on our website. So we would apply in the near future AI to those text data so that AI would produce the draft investigative report in our system. Well, some of you may want to ask me about the personal data protection and our disclosure of synthesized data or the database of individual adverse event or near-miss event. And I'd like to share with you in relation to the issue, which is a lawsuit case. A couple of years ago, a single childbirth facility and a parent sued JQ to request to withdraw synthesized investigative report from our website, which is their case. So the Tokyo District Court ruled that it dismissed the claim because the JQ's no-fault compensation system aims at public health promotion, which is one of the reasons to exempt data sharing, personal data sharing with third bodies from being banned in our Personal Data Protection Act in my country. So the JQ is now continuing to disclose all the synthesized report on our website. Here you see the video of the 7th Global Ministerial Summit on Patient Safety, which took place in Manila, Philippines in April this year. I chaired one of the plenary sessions with the title of AI and Health. Here you see Sue Sheridan from the United States. She is now sharing her experience on Bell's palsy. And I shared my experience on AI development of reporting and learning system and disclosure of synthesized report of investigative report, followed by the lawsuit at the Tokyo District Court. Okay, I'm going to share with you some takeaways. National Policy for Healthcare DX was developed, with which following initiative has been advancing along. Number 2, integration of data and platform development, such as personal app, website, to access the data are now underway. Number 3, not only healthcare institutions but patients will receive the benefit through healthcare DX like Sue Sheridan. Number 4, financial incentives are provided in medical care insurance reimbursement system by improving conditions of current fee items and introducing new items closely related to DX promotion. Number 5, AI is increasingly incorporated into EHR for clinical and administrative use, as seen in my hospital. Last but not least, massive text data in patient safety incident available on JQ's website has been contributing to AI model development. Well, that's all I have brought to you on this wonderful occasions. Thank you very much. Thank you for listening. See you soon.
Yeah, thank you very much, Professor Shin. I think the AI on health is now a hot topic. I think we will discussion about the AI and how we can use it. As you say, that strict data protection and also ensured anonymization are also very important. So next, I will introduce the next moderator, Professor Wu.
Okay, I'm Dr. Wu, Wu Zheliang. Yeah, it's now the Deputy Superintendent of Taichung Veteran General Hospital. I'm very happy to moderate this panel discussion. Today, we have the three panelists will be invited and also discuss with our two keynote speakers. The first talk from the Dr. Chen is getting the diagnosis right, the next frontier of the patient safety. And the second talk from Ushiro Shin, digitalization in healthcare and patient safety. We are very enjoy both presentation from our keynote speaker. Now I will introduce our panelists. The first we invited the Ruiting Zhang. Ruiting Zhang is a nephrologist attending physician, and also he now is the director of the Lean Healthcare Quality Management Center, Xinggong Wuhuoshi Memorial Hospital. And the second panelist is Dr. Shih-Ying Chen. Yeah, he is Deputy Superintendent, Kaohsiung Municipal Datong Hospital. He is also the professor of School of Medicine at Chang'an University. And our the third panelist is Baoling Ren. She is the Deputy Secretary General THQA and also the Assistant Professor of Department of Donghai University. So later I will invite the three panelists give some comment about these two topics, and also if you can raise the question to our speaker. And so the lady first, Pauline Ren, can you give some comments and also raise your question for the Ushiro Shin and also the Shih-Ying Chen doctor, right?
Okay, thank you to the moderator, Dr. Wu, for introducing me. It is my great honor to participate in today's discussion on patient safety. And I'd like to thank our two distinguished keynote speakers for their excellent presentations. I've been involved in and leading patient safety initiatives since 2003, when I first began this work at Puli Veterans Hospital. In 2007, I transferred to Taichung Veterans General Hospital, and with a strong support of our superintendent, undertook a project on patient safety goals surveys within the Central Taiwan Regional Healthcare Network, a role that I have now been engaged in for more than 20 years. In 2014, through Chairman Zhang Liaoming Yi, I had the privilege of visiting Kyushu University Hospital together with members of the Taiwan Patient Safety Cultural Club, among whom was our moderator, Dr. Wu. That was when I first came into contact with Professor Shin. As we all recognize changing healthcare professionals' cultural and awareness regarding patient safety requires both a well-designed strategy and strong execution. Taiwan is now entering a phase of rapid population aging, closely following Japan's path. My question for Professor Shin is, based on Japan's experience, now has patient safety culture been developed and implemented in long-term care institutions? I also have a question for Professor Chen. If the hospital could only do one thing, starting tomorrow, to improve diagnostic safety, which specific process or metric would you recommend we start with, and why? Thank you.
So Dr. Ushiro Shin, can
Yes.
you answer the first?
Yes. Yes. Thank you very much, my Taiwan colleagues and the organizer of this wonderful session. So I'm again really I feel very much honored and privileged to work in Q&A session after my presentation. And I'd like to add one more thing. In Geneva, as you see in my presentation, and in Sao Paulo, I was invited to the Taiwan group for morning group photo or a karaoke party at night. I enjoyed it very much. I'm really grateful for your kindness and goodwill that you displayed always to me. So thank you very much, Kathleen, for your question related to quality and safety improvement in long-term care setting. And fortunately or unfortunately, my country got into super aging society earlier than other countries. So for instance, I am currently working in EU, European Union, research group because most European countries are now facing the same issue, and many of the countries were used to be a part of Soviet Union. They need to develop medical care system as well as long-term care system at the same time. So I'm invited to work in the research group in EU. And my country launched a nursing care insurance system. It's a public system in 2000. And we developed a medical care insurance system in 1961. So 40 years later, we launched another public insurance system related to nursing care in 2000. And ever since, we have been developing safety culture and safety measures in nursing care settings. But the initial years, as you see, the safety activity or the safety culture were developed independently in individual long-term care facilities among many facilities. But the good news was that the relevant organization and association, for instance, Japan Association of Geriatric Health Services, services, etc., etc. There are a couple of associations like that. Those associations were established one after another in initial years, and they have been providing education and training related to safety and quality development. And but initially there was no standard, there was no national standard on safety. But in 2006, Japanese government launched the original standard, which includes production of guidance on healthcare, nursing care safety and quality, and the deployment of a person in charge of safety in nursing care facility, and education and training in nursing care facility. And after that, around 2010, the Japanese government launched a subsidy. It's a money for purchasing a robotic lift or telecommunication device in nursing care facility. And another thing is a robotic lift and telecommunication, and yes, a monitoring device for the elderly people, so that the facility would prevent those elderly people from leaving the facility. So the equipment was really got better in and around 2010. And after that, the latest knowledge on such as reporting a learning system, quality indicator, etc., were introduced to nursing care settings by those association and organization. And the last but not the least, I'd like to share with you latest news, which is financial incentive and financial disincentive. So I presented three items in standard: the deployment of a person, and the production of guidance, and the education and the training. If you do all of three, you will get more money from nursing care insurance system. However, if you lack either of them, you will you will get reduced amount of money from nursing care insurance system. This is the latest news. And yes, and last but not the least, this is the very last. As I shared with you in my presentation, nursing care data is going to be integrated with medical data and the welfare data, because now elderly people is getting all kinds of care and welfare. So we need to integrate all those data for better nursing care, medical care, and welfare. So this is sort of a history that we took over the last 2 decades. So thank you very much, Kathleen, for your question.
Okay.
Thank you.
Thank you.
Thank you.
Thank you, Ushiro Shin. You have very impressive that you integrated the medical information from the nursing home to the hospital. I think it's very, very impressive. And now, how about the Dr. Shih-Ying Chen? Can you remember your question?
Sure. Thanks
Please.
for thanks for Professor Borin's these challenging questions. I think it's difficult to answer the question, but I try to, if we dissect the whole diagnosis process, I think it involves three main components. The first part is gathering clinical information from history taking and the physical examination. And then the second part of the diagnosis process is clinical reasoning to generate a possible plausible diagnosis, the so-called differential diagnosis. And the third part is arranging diagnosis tests and correct the test result. Finally, the doctor can use all this information to make final diagnosis. Among these three components, I think the most difficult part is the clinical reasoning process. The capability of clinical reasoning of clinicians so far still pretty much depends on the basic medical training and the personal experience. Maybe we can expect, but maybe someday artificial intelligence can help in making diagnosis and provide a treatment plan for doctors, but it is clearly not now. And it's really I have to admit the AI is still not affordable in many hospitals. So I think the most practical and achievable things that I can recommend is to improve the information collecting and the transmission process. You can bridge the communication gap between patient and the doctor, especially in a busy clinics. The generative AI, I think, so far can help in reviewing and summarizing complex medical history and the previous test results of first visit patients. When he first visits, seeing the patients, the patient might have a very complex many medical histories. So the AI can help in summarize the previous medical history of new patients. I think with the help of organized management flow and the new technologies, information is essential for correct diagnosis can be corrected and passed. So I would suggest to design a timely and accurate information flow is the first step to improve diagnosis safety for most of the hospitals. That's my main point. So thanks again for this important question. Thank you.
Okay, thanks, Dr. Chen. How about the Dr. Shih-Ying Lin? Can you give some comment about the two talk and also give you a question for the speaker?
Okay. Good night, everyone. I'm Dr. Lin from Kaohsiung Changgen Memorial Hospital, as well as our new hospital, Changgen Kaohsiung Municipal Datong Hospital. Thank you, the moderator's introduction, and I really appreciate both of our keynote speaker, the Professor世英and Professor Shin Ushiro, for your very impressive and informative lecture to let us know how the AI assists quality care or the digitalization healthcare, how to integrate into our daily practice to improve the patient care. I think the Professor Chen he provide very important the hospital-based the information how to from the diagnosis. If you have the right diagnosis, definitely you can have the following to provide the patient the significant, useful, and the advancement for the patient's follow treatment or any kind of healthcare suggestion. And the Professor Shin provide the national level or the community or public. I think it definitely is quite important for our citizen or the international global the impact on this field. And I think also it at our Changgen medical system, actually we are very active to I think in Taiwan, every hospital we do our best to use the AI or any kind of digital digitalization data or structural electoral medical record to find the important and the useful and the precise data to combine. And one of for the prediction. For example, we use some of surgical medical term when the patient admission. We use the AI to predict if the patient did some to predict the patient will have the surgical complication or not. This is one of the other one is for the following down. I believe some of the hospital in Taiwan they also did very well about this kind of project. But the important and all the initial our project start. The difficulty for us is how to get the really useful and the important data or the metric or the predictor, the combine. And one of the reason is because initially we collect many of the data. We know right now the machine can help you to operate or calculate, but always you try and error, combine this one. If you have the super computer, you can do that. Otherwise, if the just the regular hospital or regional hospital, sometimes it is very difficult. But the data is from the big medical center. But some of the regional hospital, even the local hospital, the situation or the scenario is a little different. So how to apply this kind of result to the other small hospital, I think that's also a difficulty and a very important issue. So my question is for the Professor Shih-Ying Chen, Chen Shih-Ying, is the difficulty is when you provide your a kind of predictor or try to find the right diagnosis or anything. I think how to get the useful or the accurate the data or parameters or metric can give you the broad or the precise result to do the right patient care is my question. And for the Professor Shin, when we to create right now, we already use the AI predictor the surgical complication in our medical system, but at that time actually it's a nightmare. Took probably 3 years and try error again. And I know you have a very important and very impressive result for the Japan, the nation, whole nation. So the data is bigger than us. So usually how long you can complete this project, and it is the most challenging thing is from the research part to clinical use part. Usually is how long and when you will decide it is really useful to apply to your clinical practice. Thank you.
Okay. So the Dr. Chen, can you answer the first and then followed by the Ushiro Shin?
Thank you for Professor Lin's questions. I think, as I just mentioned, the AI so far is difficult to make diagnosis for doctors so far. But I think the is still a challenge, but we have to meet is I think the AI model for making diagnosis usually is developed in a large medical center, use lots of the big data to develop the model, but because you have to prove its validation in many different hospitals, so our government have very strict regulations about how to make a cross validation in cross different hospital before they can be applied from one hospital to another hospital. So this is the first thing we have to remember, that if you want to use a AI model to make diagnosis, it should be very strictly extended to make sure its validity in health clinical diagnosis first. And then the second is in applying and using this model, because so far the model cannot talk with patients, cannot do physical exams for the AI before AI robotics. So if you only have the model cannot take history for you, cannot make physical examination for you. So how clinicians can gather important and critical information and the physical findings, then put into the AI model is very important. So I think before that, this is why I emphasize the first step, and for most of the hospital can do is to create a system that the clinicians can easily and efficiently and accurately correct important informations to help them to make diagnosis. After some days, we have a very useful AI model to make diagnosis to making diagnosis. So we combine the good information data quality and the useful AI model, so you can cooperate to make a diagnosis in the future. So I think it's a challenge, but I think in many hospitals are fighting and working hard on that to develop the very valid AI model. Thank you.
Okay, and then Dr. Ushiro Shin.
Yes, yes. Thank you very much, Professor Lin, for your question related to big data for research use. And as I said in my presentation, the project to share integrated healthcare data with research industries is already now underway. The project has already begun. And there's a couple of companies who anonymizes the data and share the data and sell the data to, for instance, pharmaceutical industry or medical device industries have been already licensed by the Minister of Health. And then actually, the healthcare data in my hospital, Kyushu University Medical Center, has been already shared with one of the companies. So maybe our data will be anonymized quickly, and then it will be shared with pharmaceutical industries, maybe this year or next year. But the problem is that my hospital is a university medical center. We have a lot of resources. We have robust data server. However, the small in my country, there are many small and mid-sized hospitals whose healthcare system is not very much robust, and the data server is not compatible with the project. So I guess that only University Medical Center and the medical centers comparable to University Medical Center can share their data with the anonymizing corporation. So that's one of the hurdle to address. And another hurdle is, as you see, the cost. This project is really costly, and nobody wants to pay a lot of money. I don't know if they want to pay the money for the future research and development. Now we are still taking a baby step in this project. And in my presentation, I also show the Gantt chart of data integration of healthcare, medical data, nursing care data, welfare data. And the Gantt chart is moving very slowly, also due to financial problem. So maybe it will take some more years to complete it. That's the status quo in my country. Thank you very much.
So if the data can be shared from the hospital, nursing home, and the welfare system, I think very important. But as Ushiro Shin said that money is important. So finally, I will invite the rating Zhang, Dr. Zhang, give some comment. Yeah, Dr. Zhang, please.
Thank you, Professor Wu. I'm Jieting Zhang from Xinguang Wu Hoshi Memorial Hospital in Taipei. Thank you very much for the opportunity to join this discussion. I want to express my sincere appreciation to the organizer, moderators, and all participants for creating such a meaningful session. Both keynote presentation were truly insightful and demonstrated the critical role of innovation and systemic thinking in advanced patient safety. However, I have two questions for our distinguished speakers. For Professor Chen, thank you for your excellent presentation. Since diagnostic accuracy is essential to patient safety, what do you see as the most effective strategies for reducing diagnostic errors in real clinical practice, especially under time pressure? And I have another question for Dr. Shin. Your presentation on digital transformation was inspiring. How do you think healthcare institutions can balance rapid AI adoption with appropriate governance to maintain trust and minimize unintended harm? Thank you.
Okay, Dr. Chen, please.
Yeah, thank you for these good questions. I think what I expected more is the very useful artificial intelligence model that can help me to make diagnosis within 1 or 2 seconds. But before that, it may be in the future, but not for now. So I think the most important still remains how we create a system or a management or process flow to help the doctors to first to help the patients to express to all their important clinical information about the symptom, duration, characteristics of the symptom, all this kind of information to the patient, to the doctor. And the doctor can very quickly catch the important clinical informations from maybe a patient, a cancer patient, have been received many course of the chemotherapy, many kinds of complications during the treatments. So the medical history should be very complex. So I think that maybe we can. The first step is we can create a process, and sometimes maybe with the help of the generative AI to review and summarize all these clinical informations very quickly and provides to the clinicians, so the clinician can um, uh, have all this important information very quickly and incorporate into their clinical reasoning to make good and correct diagnosis. So I think maybe in the more early part of the diagnosis process. So I think so far, I think the most practical thing is to create a system that facilitates the information collection and transmission and the processing. Thank you.
Okay, thank you, Dr. Chen. And now I will, Dr. Ushiro Shin, can you give some your answer?
Okay. Thank you very much, Dr. Chan, for your question. So, in the interest of time, I would be very brief. In my hospital, the expert in healthcare data division always warn physicians on hallucination issue. Hallucination is sort of a fake data, fake information produced by AI. So our staff is always cautious about the product of AI, and we must finally confirm on our own the product. So we are really careful about that. And I described AI Act, which passed our diet this year, and I emphasize that the AI Act is trying to balance the benefit and harm. Benefit, yes. I once listened to a speech of a professor of Tokyo University who is an expert of AI and contributed to the AI Act. And he says that he doesn't know what will happen if we apply AI to our daily lives. But if we are too careful about hallucination or fake data, nothing would progress. So he emphasized the reporting system of hallucination or fake data or misled products is quite important. So the AI Act includes articles related to the launch of reporting system of hallucination and fake data produced by AI. So that we would improve our AI models in my country. So I believe that try and error will happen in coming years. Thank you very much.
Thank you.
Okay, thank you, the Ushiro Shin. I think today's discussion will be many give us more, not the final answer, but just give us more challenge, including the regulation, including the money, and also the technique, and also to our patient. So our society can be consider the next symposium in this issue, but because the time is limited, I have to hand over to the moderator, to our chair, the Dr. Huang.
Thank you, Professor Wu, and thanks for the expert to participate in our QA and SQA medical quality webinar. Tonight we have a wonderful discussion about the patient safety and also AI art from the expert from Japan, Professor Shin, and also Taiwan expert. So please follow up at our SQA and the Taiwan Healthcare Quality website. We will keep to provide the best quality webinar to improve the quality care of the world. Thanks much for your joining tonight. Thank you. Have a good night. Bye.
Thank you. Have a good night.
Good night.
Bye.
Thank you, Professor Shin, for
Thank you very much.
accepting
Thank you.
our association's invitation and sharing your experience.